older children, adults, and even in elderly. It was first reported by Buryan et al. In 1958, and it was thought to be a rare entity. There were limited reports about this disease. But Jacobs and colleagues reported 174 cases of acute comittant ET, and they stated that it is not as rare as once thought to be. Monet et al. In their report found that it is the third most common type after accommodative ET and intermittent ET. Feng et al. Reported that there is tenfold rise in accommodative ET and acute comittant ET during the last 10 to 15 years, that is between 2009 to 2017, the time when there is increased availability and use of smartphone all over the world. And there are postulates that excessive near work, including gadgets and near work in the form of mobile phones, has a role in the development of acute comittant ET. With the advent of COVID-19 and universal lockdown, there has been an increased incidence of acute comittant ET all over the world. This is a study done in our hospital to assess the clinical characteristics of patients who developed acute comittant ET during the COVID-19 time. We got 16 patients over a period of 12 months. It was actually the double of the previous year's records. We had the only precipitating factor was increased screen time of at least 4 hours or more for at least 3 months or more. Majority of our patients, that means 14 out of 16 patients had this history of increased screen time. So when we searched literature, we found that there are reports that there is increased surge of acute comittant ET during the last few years. These are actually the reports from Kerala by Dr. Lailan Mohan et al. And Dr. Nina et al. They, in their independent studies, reports that there is increased surge of acute comittant esotropia during the last 2 years, and perhaps due to the increased near activity in the form of mobile phones. Cheng et al. Described the clinical characteristics of acute comittant esotropia. We have already discussed that. Usually these patients present with acute non-accommodative type of ET with a diplopia. Usually the deviation is large angle, more than 25 PD, and the age of onset is more than 5 years. It rarely resolves spontaneously. Then what is the reason for acute comittant esotropia? Binocular function is usually stable above 5 years. So a reason need to be sought to the loss of fusion in acute comittant esotropia. Acute comittant esotropia is divided into 3 types: Swan type, Buryan type, and Belshovsky type. Swan type is due to the disruption of the binocularity by patching one eye or uniocular occlusion. In Buryan's type, there is actually no known etiological factors are defined. It can have minimal hypermetropia, sometimes associated with psychological or physical stress. In Belshovsky type, usually associated with myopia, and the reason for developing acute comittant esotropia is convergent spasm. Here, in the type 1 and type 3, there is definitive cause for the loss of fusion, but in type 2, there is no clear cause for the breakdown of fusion and the development of acute comittant ET. So there is concern about the underlying pathology. So we found that children with intracranial pathology, particularly posterior fossa tumors, can present in this way. There are various reports. Leon and et al. Find out in their study, 1 out of 10 patients had CNS pathology. Liu et al. Found that 40% of the esotropia due to neurological cause were comittant. The rest only are incomittant. There are multiple reports that acute comittant ET is the only manifestation of a posterior fossa tumor. Usual associations are Arnold-Chiari malformation, tumors of the cerebellum, pons, and corpus callosum. Von Nuden labeled this type of acute comittant ET as acute comittant ET related to intracranial pathology. Usually neurological disease produce incomittant strabismus. But why acute comittant ET in neurological diseases? Actually, the reason is not clear. Hoyt and Good reasoned it may be due to the involvement of supranuclear mesencephalic structures which controls the vergence eye movement. Jambolsky et al. Proposed that it may be due to an infranuclear insult that may result in a bilateral 6-nerve palsy with the spread of comittants. These are the various etiological factors like uncorrected myopia, disruption of binocularity, psychological stress, neurological factors, decompensated phorias, etc. were the proposed etiologies from time to time they reported. But the exact etiology of acute comittant esotropia remains inconclusive. COVID-19 has changed our lives dramatically. So with the introduction of web-based classes and personal tasks during the last few years, there is a surge in acute comittant esotropia. Feng et al. Reported that smartphone use of more than 5 hours per day was a predominant observation among their patients with acute comittant esotropia. 20 out of 26 patients had history of more than 5 hours of smartphone use. Hayao Siok et al. Found that gadget use at close distance can result in acute comittant ET, and refraining from it cause resolution of acute comittant ET, which partially supports this observation. The postulate that the excessive nerve may lead to imbalance between convergence and divergence, that lead to increased tone of the medial rectus muscle, and that can result in acute comittant ET. Then coming to the evaluation and management, we have to take a careful history, including any precipitating factors like fever, stress, or any monocular occlusion. Then history of previous treatment, onset and progression of the disease, any associated features, etc. And a thorough ophthalmic examination, including anterior and posterior segment examination to rule out any organic pathology. And coming to the investigations, is imaging needed in all cases? Actually, there is no single clinical sign that can reliably indicate the rare patient harboring a tumor. So a high index of suspicion should be maintained. Bush et al. Found 4 significant risk factors for intracranial disease associated with acute comittant ET. They are larger ET at distance, recurrence of acute comittant ET, neurological signs like papilledema, older age at onset. 50% of the posterior fossa tumor are reported to be present only as acute comittant ET without any other significant neurological feature. So it is clinician's decision to whether to order for imaging or not. Coming to the treatment, surgery is the gold standard of treatment. We usually plan surgery after 2 to 3 months. By the time we wait for any spontaneous restitution. During the meantime, we can treat, if there is any refractive error, we can treat, and we can go for amblyopia treatment if at all amblyopia is present. Recently, botulinum toxin is found to be a new treatment option for acute comittant ET. There are reports by Dawson et al., Duo et al., and Wang et al. In their report, they suggest that they got impressive result with injection botulinum toxin in acute comittant esotropia, even though their sample size was limited. There are reports that injection botulinum toxin A is equally effective as surgery in acute comittant ET. The study done in our hospital also showed a good success rate. We got a 87.5 success rate with the injection botulinum toxin. So in our study points that botulinum toxin A is effective and safe in acute comittant ET. In a nutshell, acute comittant ET is not as rare as once we thought. Increased incidence of acute comittant ET during the last few years may be related to the increased near work or smartphone use. The exact etiology of acute comittant ET is elusive. Uncorrected myopia, accommodative element, physical or psychological stress, decompensated esophorias, neurological disorders, etc. are proposed to be the cause. Being comittant, it may provide some reassurance that an underlying neurological lesion is unlikely, but by no means it guarantees it. The role of increased screen time in the development of acute comittant ET is yet to be identified. Botox injection A to the medial rectus has found to be an effective and safe treatment for acute comittant ET, and it is deemed to be an alternative treatment to the traditional surgery. Thank you.
Thank you, Dr. Arun, for that wonderful highlighting about a universal problem seen after COVID times nowadays among all strabismologists and ophthalmologists, general ophthalmologists.